Good morning, everyone. Thanks for joining us. I'm Tom Martin at the University of California, San Francisco in San Francisco. And I'm one of the myeloma doctors at UCSF. And thanks, Joe, for the introduction. I usually prefer to be together because I can actually see if you guys are believing what I'm saying. If I can talk to you about future therapies to see which ones I'm excited about and see which ones you're most excited about. But so here we go. We're going to talk about future therapies in myeloma, one of my favorite things to talk about. Now, we have a variety of different classes of drugs that are being tested currently in relapse refractory myeloma. And particularly it's in patients that have our new unmet need, and that's triple class refractory myeloma. In those patients, we can use chemotherapy, standard alkylator-based or Cytoxan-based chemotherapy, and it does work, but it does provide a fair amount of toxicity. Other approved drugs actually are panobinostat, which sometimes we can combine with proteasome inhibitors, and selinexor, which we'll talk more about in a minute. But in development, we have a fair number of new monoclonal antibodies, one that was recently approved, isatuximab, a new CD38 antibody. And then we have a variety of IMiDs, or now called CELMoDs, CC220, otherwise known as iberdomide, CC92480, otherwise known as 480, Venetoclax, Melflufen. We'll talk about these. And then we have some exciting anti-BCMA targeted drugs. We have antibody drug conjugates, we have bispecific T-cell engagers, and then we have CAR T-cells, and we'll save that for the end. So I'll start off with iberdomide, CC220, which is a next generation CELMoD. It is more potent in terms of preclinically and its ability to inhibit Ikaros and Aiolos to degrade those proteins, more potent than pomalidomide, more potent than lenalidomide. And in the bottom left of the slide, it also is more potent with IL-2 secretion from lymphocytes. So it can be potentially combined with antibodies and have a more robust immune or a pro-immune effect. Well, these are data that actually was presented by Sagar Lonial back in ASCO of 2019. It was a phase 1 study using this oral medication in combination with dexamethasone. It was in relapse and refractory myeloma. The patients had prior lenalidomide 100% or pomalidomide, and 3/4 of them actually had prior daratumumab. Now, the plan was to do multiple cohorts, but I'm going to talk to you specifically about the IBER plus Dex cohort. This is a standard dose escalation trial. And in all comers, 59 patients that were treated with dose escalation, the overall response rate in actually a fairly refractory population, the average prior lines of therapy was 5, was 32%. Really, I think, an active drug together with dexamethasone. If we look at truly the IMiD refractory, and most of those were lenalidomide refractory, which is really a tough population, the overall response rate was still 35%. And if we look at patients that were DARA and pomalidomide refractory, again, still an overall response rate of 30%. Very interesting. Now, what Dr. Lonial discussed during his presentation was that the drug was actually extremely well tolerated. In terms of grade 3 and 4 events, there was no grade 3 or 4 fatigue, no peripheral neuropathy or worsening peripheral neuropathy, and no significant diarrhea. The biggest thing was infections. And as we test these kind of immune type drugs in myeloma, infections always come up as one of the biggest toxicities that we see. There was also some bone marrow suppression, but really early data that this is an active drug. It's probably going to be more active than pomalidomide, which is amazing. Now, more recently at ASCO, Paul Richardson presented data from CC92480, otherwise known as 480. It's a next generation, actually, CELMoD. And in fact, this is a phase 1 dose escalation trial. They tried a variety of different schedules too. So this was really a neat adaptive Bayesian design. But at the end of the day, what they found out is the 21 out of 28 day dosing schema was actually the best. And below is looking at overall response rates. The whole group overall response rate, again, in a refractory population, 6 prior lines of therapy, 70% DARA exposed. And really 50% of the patients were triple class refractory. And in patients that had received the 10 out of 14 days, 2 sets for a 28-day schedule, had an overall response rate of 40%, but a better schedule doing 21 out of 28 days, an overall response rate of just over 50%. Pretty dramatic. And what Dr. Richardson presented was there was a fair number of people, over a third of the patients had extramedullary disease. And this is one of the examples that he gave, which I thought was really quite interesting, looking at a hepatic extramedullary disease, showing a pre and a post PET scan, showing a dramatic response in liver disease. This is really interesting and quite a effective drug. All right, let's move on. Now, Venetoclax, as you know, is a selective small molecule oral BCL2 inhibitor, and it was first found to be active as a single agent in refractory myeloma with a response rate in the order of 20%. But it was more active in patients that had the 11 and 14 translocation. Now, other researchers, including researchers at Emory and across the world, showed that Venetoclax, in fact, it suppresses BCL2, but can be used in combination with dexamethasone or proteasome inhibitors and potentially have synergistic effects. So they went on to do a phase 2 study with Venetoclax with bortezomib and dexamethasone, which did look positive, and led us to a phase 3 trial, the Bellini trial. And in the Bellini trial, patients were randomized to receive triple drug therapy, Venetoclax plus bortezomib and dex, 1 to 3 prior lines of therapy, versus placebo bortezomib and dex. And although there was a nice improvement in progression-free survival, there actually was a decreased overall survival. And in fact, this Bellini trial was closed early due to increased deaths in the triple drug arm with Venetoclax, bortezomib, and dexamethasone, with increased deaths seen due to infection and also to cardiac issues. And in that regard, this study again was closed, and probably development outside of 11-14 translocation patients is really at a standstill. Now, if we look specifically at the 11-14 patients in the upper bar here to the left, you see that basically there was a very high response rate and a really amazing progression-free survival not reached in the Venetoclax plus bortezomib dex versus basically about 9 months in the combined bortezomib dexamethasone group, a dramatic improvement. And there was also an improvement in the overall survival curves favoring the triple drug. So again, this combination is very effective in the 11-14s, and Venetoclax will move forward in that group of patients. We're looking to see more of it. Now, what about selinexor? Selinexor is basically, as you know, a novel drug. It inhibits nuclear export of some important tumor suppressor proteins. It keeps p53 and other tumor suppressor proteins in the nucleus where they actually can have their normal activity. They can control cell cycle, and therefore cancer cells can't have this abnormal cell cycle, et cetera. There's other effects, but certainly has a dramatic effect in patients that have refractory multiple myeloma. In the STORM trial, which was selinexor together with dexamethasone, they tested over 120 patients. These patients had a mean prior regimens of 7. The majority of the patients, 25% of them were pentarefractory, and using selinexor at 80 milligrams twice weekly with dexamethasone 20 milligrams twice weekly, the overall response rate in this really refractory population was right around 25%. Progression-free survival is short, only 3.7 months, but those that responded, the right side of this curve, either the patients that had a minor response or a PR, actually had prolonged overall survival. And so it's actually quite effective in some patients. Now, I think we all have had a chance to use it, and we've all seen that actually for some patients, you're quite surprised that they have such good responses. But there are toxicities from selinexor, and these are things that we have to watch out. You can't just give them selinexor and dex and follow them. You have to actually see them at least weekly, if not twice weekly in clinic for blood tests to look at their sodium level, give them salt replacement, IV hydration with saline, salt tablets. They do need, I would say, at least 2 drugs for anti-nausea. Ondansetron, olanzapine work quite well. We often use methylphenidate to increase their energy, to decrease fatigue, and we also use cytokines as support. And with those supportive care measures, patients can stay on it, especially those people who respond after the first or second cycle of therapy. Now, it is being combined with other drugs, and we'll see if it's less toxic as a weekly administration. Now, the next drug I'll talk about is Melflufen. Melflufen is a novel lipophilic peptide conjugated to an alkylating agent, melphalan derivative. And so this lipophilic peptide increases the influx of this drug into cancer cells like myeloma cells. But those cancer cells actually have inside the cell an increased amount of aminopeptidases. These aminopeptidases cleave the lipophilic peptide from the alkylator, and it really traps the alkylator in the cells. In other cells in which this gets in, where they don't have high amounts of aminopeptidases, the drug can get in the cells, and then it also can get out of the cells. So hopefully that increases the cytotoxicity on cancer cells. Myeloma cells have increased aminopeptidases as well as some other cancers. Well, there's been a number of trials using Melflufen, but the most recent one is a phase 2 Horizon trial on the right side of this slide. And Melflufen is given IV over 30 minutes at 40 milligrams every 4 weeks. It's actually a fairly easy drug to administer together with weekly dexamethasone. And in this Horizon trial, it was patients that had 2 or more prior lines of therapy. They were relapse refractory. They were had 5 prior lines of therapy. 91% of them were double refractory. 80% of them were dara refractory. And this had a very high number of patients with high-risk cytogenetics, over 60%. And in this really refractory population, they had an overall response rate of 28%. PFS is about 4 months, and the median overall survival is 11.2 months. Now, in this really refractory population, this is actually a very impressive result. And again, it's very easy to give. It's, in my mind, well tolerated and basically associated with some blood count suppression, and that's the majority of the toxicity, and some mild GI toxicity. Now, it is possible that this drug might get approved from the phase 2 data, but we'll just have to see over time. And there are other phase 3 trials that are ongoing. So let's go on to the next generation, some of my favorite new drugs. We're going to talk about some of these therapeutics that target BCMA. We'll talk about antibody drug conjugates. I'll give you an example of a next generation CD38 antibody. And then we'll talk about some of these dual targeted antibodies, these bispecific T-cell engagers. An example of this is in the middle of the slide, where you see that these drugs, although there's 10 or 15 companies in the market for these, they're all designed a little bit different and have a little different structure. This one from TineoBio actually has a bivalent binder to BCMA, and on the other arm has a low affinity binder to CD3. And potentially, if it's a lower affinity binder, they may have less T-cell activation and maybe less cytokine storm and less side effects. So every one of these drugs, and we have drugs from Amgen, Celgene, Janssen, Pfizer, TineoBio, Regeneron, et cetera. There's many in the market. They may actually have differences in their toxicity as well as their efficacy. We'll just have to see. Now, I'm going to first talk about belantamab mafodotin, which is a BCMA-targeted antibody drug conjugate. It has 4 potential mechanisms of action. Traditional ADC, where it binds to BCMA, gets internalized. The poison basically is cleaved off the antibody, and the poison then causes cell death. It also can work by antibody-dependent cellular cytotoxicity as enhanced Fc domain. It may also block BCMA and cause a signal for apoptosis, and it works by an immunogenic cell death. And so this is a drug that, in fact, last night was approved for use in the U.S. So this drug actually we'll soon have access to, and it was really based on this phase, essentially a phase 2 study. This is data from the DREAM-2 study. The drug is called belantamab mafodotin. Again, it's the first ADC that's approved in multiple myeloma. This was in triple class exposed patients. Again, it was a phase 2, is a randomized phase 2. It was between two doses, belantamab 3.4 milligrams per kilogram given every 3 weeks versus 2.5 milligrams per kilogram given every 3 weeks, about 100 patients in each arm. And here are the overall response rates on the right side of this. Overall response rate at 2.5 was 31%, and at 3.4 was 34%. So these are patients that were essentially exposed, triple class exposed. The majority of them are DARA refractory. And so this is a really good response rate, over 30% for patients that are triple class exposed and DARA refractory. PFS was 3 months in the 2.5 and about 5 months in the 3.4. The big toxicity, I'll talk about it more in a second, is keratopathy, where they get inflammation at the surface of the eye due to the MMAF toxin that's the binder to this. But the difference actually was in the thrombocytopenia, a known toxicity to this toxin. It was 35% at the 2.5 milligram and 59% at the 3.4. So with everything being fairly similar, the company decided to take the 2.5 milligrams per kilogram to the clinical dose that we will use now that it's approved. Now, we do have to look at side effects. Again, the corneal events was about 71%, thrombocytopenia at 35%. This is at the 2.5 milligrams. The corneal events are events that can be seen by the ophthalmologist. This drug has to be given in collaboration with your local ophthalmologist. Common symptoms are blurred vision and dry eyes. Manageable, mostly with dose delays and dose reductions. More than half the patients have to have dose delays and dose reductions. And there were some hematologic toxicity, again, thrombocytopenia, mild anemia, mild neutropenia. Infusion-related reactions were seen in 21%, usually occurred with the first dose, manageable, and didn't recur in subsequent dosings. And so this is a drug that we're going to get familiar with. Going forward, combinations of these drugs are basically in clinical trial. There's phase 3 trials that are ongoing. And the question is can we use even a lower dose and have less ocular toxicity? Can we space out the dosing in combination with other medications? So we're going to learn over time how to better use this drug. That is for sure. Let's move on to BCMA-specific antibodies. This is probably the class of drugs that I have the most encouragement and optimism for. We heard at ASCO 2009 from Dr. Top about AMG 420, the first bispecific T-cell engager. This was a true BiTE from Amgen, where it's a very small molecule, so short half-life, bound to BCMA and CD3. And it at a maximum tolerated dose of 400 micrograms in 10 patients treated, they showed an overall response rate of 70%, with 5 of the patients having an MRD bone marrow. Really amazing. Now, the development of this actually was halted because of the continuous infusion nature, and there's so many other drugs that are going to be easier to give, in development, including one that was just recently presented at ASH 2019 by Luciana Costa. This is from Celgene, or now BMS, CC93269. This is a first-in-man study, again, in relapse refractory myeloma. The primary objective here was actually to define dosing. They did standard dosing increase, and then they did step-up dosing. They treated 30 patients. At the step-up dose, the higher doses, 6 to 10, or the 10 milligrams, which they presented data on 9 patients at ASH, 8 out of the 9 patients had responses. And I'll show you that these responses were deep in the red. So the majority of them had stringent CRs. And in fact, the majority of those patients had MRD negative bone marrow responses. And here's the M protein and free light chains over time, showing that even out 200 days, these do look durable. So now this is early data, right? So at ASCO this year, we also got a presentation from Dr. Osmani of teclistamab, another basically BCMA CD3 bispecific T-cell engager. And here's the structure on the upper right. This study enrolled 78 patients. These very refractory, 6 prior lines of therapy. 80% of them were triple class refractory, and they dose escalated up to 270 at this current time, and they're still going up. I'll show you data at the 270. But the patients that received basically 38 micrograms per kilogram or more there was some CRS, 50 to 70% of patients CRS. So they're activating the T cells for sure. Minimal neurotoxicity, about 10%. But the overall response rate at the 200 70 micrograms, 70%. And again, some of them look durable. Very encouraging data. All right, well, I'm going to end in the next minute and a half on CAR T cells. You know, we initially thought CAR T cells certainly a game changer for myeloma. Now CAR T cells targeting CD19, BCMA, SLAMF7, GPRC5D, many different ones in clinical trial, using a variety of different gene transfer vectors, extracellular domains, and signaling domains. And all of these CARs actually will be a little bit different. But here's the four that are the most advanced. BB2121, also now known as ide-cel, J&J 4528, JCAR H125, in the CAR from the BCMA CAR from Poseida. Now, all of these have shown in early phase trials dramatic response rates between 60 to as many as 100%. And the majority of them do have CRS, as well as some mild neurotoxicity. We'll have to see in the Poseida product as we get higher doses, whether this low incidence of CRS actually is true to this one. And there's many reasons why, of which you guys can ask questions later, et cetera. But in fact, these are all very exciting products. Now, the problem with myeloma, and this is a PFS curve, which we have the most data from BB2121, that over time, patients with myeloma continue to relapse. Different than non-Hodgkin's lymphoma, where they actually stay in remission for long-term and potentially may in fact be cured. Even those patients that achieve bone marrow, MRD negative bone marrow responses relapse over time. What the reserve is, I don't know. These are data from ASH last year using the J&J compound. Look at how deep the responses are, 100% response rate. And initially, it looks like these patients are having durable responses. We have to follow this over time. It's really hard to say if this is different population than the BB2121, the same, or how patients are going to do in terms of the PFS. We'll see over time. So in conclusion, you know, triple class refractory myeloma is an unmet need. Selinexor currently available. Just watch out for toxicity. Belantamab, it'll soon be available. It'll hopefully soon be in drugstores that we can use it actually, and we can have it in our own pharmacies. There's many other promising drugs, Melflufen, Venetoclax, these novel cell mods. The bispecific T-cell engagers, I think, are going to dramatically change the platform and our treatment of relapse refractory, early relapse, newly diagnosed myeloma, and I think eventually smoldering myeloma. And then CAR T cells, obviously very encouraging data. You know, the next generation CARs, we're here and we all want to get here. And I think when we get here, we're going to have dual targets, safety switches, immune, improved T cell expansion, et cetera, et cetera. And at the end of the day, I think we are going to be able to cure more patients with myeloma. Thank you for your attention.